Good day, dear students. Good morning for students who is in Russia now. Our lecture for today called Diagnostic Methods for Stable Coronary Artery Disease, Arterial Hypertension, and Arrhythmias. We'll discuss mostly about method which detect electrical activity of the heart and also vascular tone. And we'll start with ambulatory ECG monitoring or Holter monitoring, 24-hour ECG monitoring. Ambulatory ECG is typically used to evaluate symptoms such as syncope, dizziness, chest pain, palpitations, or shortness of breath, which may correlate with intermittent cardiac arrhythmias. Additionally, ambulatory ECG is used to evaluate patient response to initiation, revision, or discontinuation of antiarrhythmic drug therapy and to assess prognosis in specific clinical context. So now, 24-hour ECG monitoring mostly is recommended for arrhythmia, for diagnosis of arrhythmia. In previous guidelines, there are two main indications, arrhythmias and ischemic heart disease. But ST-segment depression is difficult to find when patient move. So main indication nowadays is arrhythmia. And I want to go back to the history. In the right picture, you can see first Holter monitor which was created by a doctor whose name is Holter. And this monitor was big, heavy, and it was very difficult to wear this monitor. But nowadays, monitors became smaller. You see it in the picture from the left side. You see, we place monitor, small computer device with different program on patient waist and contact it with electrode which placed to the patient chest. Mostly, there are three leads in most commonly used 24-hour ECG monitors. And for these three leads, we need 7 electrodes. Advantages and limitation for Holter monitor. Advantages: ability to record and document continuous 3 to 12 lead ECG signal during normal daily activities. Familiarity of physician with analysis software programs that generate preliminary diagnostic reports. Limitations: frequent non-compliance with symptoms and event markers. Frequent electrode detachment. Signal quality issues due to skin adherence artifact. Absence of real-time data analysis. Poor patient acceptance of via electrode system. So for what do we use Holter monitor in real practice? We use it to detect arrhythmias which come and go. When patient come to the doctor and doctor takes ECG from him, it may be normal. But patient may have complaints of paroxysm of palpitation, episodes of palpitation during daily activities. That's why we recommend patient to wear 24-hour ECG monitor and to detect these arrhythmias. And to analyze these long-lasting ECG records, we need software, and computer always helps doctor don't miss some arrhythmias, but have to be interaction between doctor and computer program, because computer program sometimes make mistake and doctor have to control a result of computer analysis. There are some limitations, mostly due to poor contact of electrodes with chest wall and due to large amount of electrodes and the wire. That's why there are new generation of long-lasting ECD records, and I'll tell you later about some of them to which helps us uh, to avoid these limitations. What can we analyze in 24-hour ECG? Arrhythmia analysis, first of all. ST analysis can be done less sensitive than arrhythmia analysis, but also possible to use it for detection of ST depression in patients with coronary artery disease. And the last one, mostly used in scientific research, is heart rate variability. And height rate variability include different analyses and mostly shows us the tone of nervous system, sympathetic and parasympathetic nervous system. And I want you to show some pictures from 24-hour ECG electrode. You see here many small QRS complexes. QRS wave, R wave mostly is visible. They are very, very small. Each line lasts 1 minute. And in the upper patch, you can see another heart rate. This device detects paroxysm of supraventricular tachycardia, and computer analyze it, enlarge it, and present to the doctor as a rule. So computer find this paroxysm, enlarge it, and now we can see sinus rhythm, then paroxysm of supraventricular tachycardia, and then again sinus rhythm. Doctor who see 24-hour monitor have to print this pathological part to confirm pathology which present in the patient, to confirm the diagnosis of paroxysmal supraventricular tachycardia. Here another example of pathology. In the upper part, you may see supraventricular extrasystem in the middle, more short interval before extrasystem and after it present pause. In the lower part, you can see couple supraventricular extrasystems in the middle, two extrasystal, two premature contractions together. What else can we detect? Also, you can detect ventricular extrasystem. You can see in the upper ECG two separate monomorphic ventricular extrasystems, and in the low ECG you may see couple ventricular extrasystems, also monomorphic. They are both together. Also, I told you in indications, we may use it not only for tachyarrhythmias, we may use 24-hour monitoring for blocks. Here is a patient with sinus problems, with sick sinus syndrome. Sinus node not work properly. You see, sometimes it stop and device detect long-lasting pause. And if rhythm restore, it is not sinus because before P wave not present, before QRS complex not present normal P wave. It is absent or it is negative. Here you can see two ECGs of the same patient. Upper ECG, when patient is at rest, heart rhythm is normal. Low ECG shows us tachycardia, and during tachycardia, you may see obvious ST segment depression, which indicate angina in this patient. Now I want to tell you few words about heart rate variability. What does it mean? Heart rate variability means different interval between normal QRS complexes. When we are speaking about sinus rhythm, we always are thinking that it is regular. But really, especially in young persons, due to different level of activity of sympathetic and parasympathetic system, may be different RR interval. And it is normal situation. And 24-hour monitoring or even more shorter period of monitoring helps us to detect this heart rate variability. Maybe use two types of analysis, time domain analysis and frequency domain analysis. If heart rate variability is high, it is possible, especially for young. It is maybe normal. And if it is low, it is not so good. Reduced heart rate variability is generally associated with an elevated sympathetic tone or reduced parasympathetic activity. Activation of the autonomic nervous system can contribute to the genesis of a variety of arrhythmias, including both brady and tachyarrhythmias. Decreased heart rate variability values have been consistently reported in post-MI patient and heart failure patients. So heart rate variability, as a rule, reduced in patients after myocardial infarction and with significant heart failure. So it is pathological feature. Studies have demonstrated the correlation of depressed heart rate variability with risk of mortality, including cardiovascular death, but not with sudden cardiac death, not with sudden cardiac death. So, decreased heart rate variability correlate with more high level of mortality. It is not good feature for prognosis, but it doesn't correlate with some specific problem. That's why in real clinical practice it's not so commonly used. Mostly it's used in scientific reports. And now I want to show you a few new techniques to avoid limitation of Holter monitor, so-called patch monitor. In this case, there are only few electrodes, three electrodes very close to each other and one separate. There are not so many wires. They don't disturb patient too much and compliance of patient is good. But if electrodes are very closely to each other, amplitude of P wave QRS complex and T wave is very small and very difficult for doctor to see small pathology, especially P wave pathology. So this monitor also has some limitation. Mobile cardiac telemetry. In this case, patient may translate ECG signal in real time to the doctor, uh, or it may be controlled by some computer. And if present some arrhythmia in the doctor room, computer will create alarm signal and doctor will know that this patient has some problem and may call to the patient and give some advice which tablet to use and maybe to go to the hospital, maybe lie down, or this arrhythmia is not so dangerous, he can continue his activity. Patch ECG monitors. Advantages. Long-term recording of 14 days or longer. Excellent patient acceptance. So patient not disturbed by wires, that's why possible to do long-term recording. Limitations. Records a limited ECG from closely spaced electrodes comprising a time series of P, Q, R, NST, and T wave sequences with low voltage amplitude. Inconsistent optimal ECG signal quality due to varying body types. So also limitations present. Mobile cardiac telemetry. Advantages. Multilinear MCT device can record 3-lead electrocardiogram, hence has a much higher sensitivity and specificity of arrhythmia detection as compared to single-lead device. Can stream the data continuously to caregivers. Immediate alarm generation upon an event detection without patient interaction. Limitation. Electrode via MCTs require daily electrode changes, and thus patient acceptance is reduced for long-term monitoring applications. Different types of monitoring is preferable in different situations, different types of ECG records. If you have many types of ECG device, you may use different in different situations. If duration of records is less than 1 minute, it called event recorder, and it's present in patient chest, but it is switched on only when sense some pathological rhythm, and this device record it. And it may be used for palpitations, and its sensitivity for it around half of episodes of palpitation. Not useful for syncope or stroke or atrial fibrillation. Standard holder usually used for 1 or 2 days, and it shows us episodes of palpitations, can show syncope and cryptogenic stroke, but also sensitivity is low. If we prolong time of monitoring, it increases the possibility of detection of paroxysmal arrhythmias. Not every day may come arrhythmias, that's why more long time of ECG records increase probability of correct diagnosis. In 3-7 days, you may use patch electrode, MCT electrode, and can detect palpitations, syncope, and stroke. 1-4 weeks, also patch and MCT, and maybe implantable loop recorder when electrode is not outside of patient body, when it is inside. Of course, in this case, the high sensitivity for arrhythmias, the highest probability of proper diagnosis, but it is invisible procedure. Some ambulatory ECG devices also have multiple biological signal sensors that allow for simultaneous recording of multilinear ECGs along with respiratory rate, peripheral oxygen saturation, physical activity, skin temperature, arterial pulse pressure to provide the comprehensive evaluation of patients with complex disorders such as heart failure or sleep apnea syndrome. For example, in case of sleep apnea, you may monitor which detect simultaneously encephalogram, ECG, BP, respiratory rate, and saturation. And all these records are changing during sleep apnea, and they change it at the same time, and this simultaneous analysis may help us in making correct diagnosis. But most commonly used combine ECG and BP monitor. It includes device with electrodes which placed on the chest wall for ECG signal, and cuff which placed on the patient arm for BP measurement. Usually, ECG detects all the time, but BP in this case mostly measured periodically. We'll discuss now more about 24, we'll speak more about 24-hour ambulatory blood pressure monitoring. Not about combined monitoring now, especially for ambulatory BP monitoring. How does it look like? Device on patient wrist and on patient waist, on patient waist device placed and a cuff on patient shadow. The most useful information includes the 24-hour average blood pressure, the average daytime blood pressure, the average nighttime blood pressure, and the calculated percentage drop in blood pressure at night. Patients define as deepest if their nocturnal BP falls by 10 to 20% of the daytime average BP value. So, in case of 24-hour BP monitoring, as a rule, BP measured periodically. At daytime, it measured each 30 minutes and at night, each 15 minutes, and at night, each 30 minutes. Then, all BP values, which may vary during different measurement, summarized and divided to the amount of measurements and calculated over average 24-hour blood pressure. At night, also calculated average nighttime blood pressure and at daytime. In normal situation, in healthy person, nighttime blood pressure usually is lower than daytime blood pressure, and normally it falls to 10-20%. And when there is 24-hour BP monitoring, which call ambulatory BP monitoring, there are another norm for hypertension. If we measure office BP, we are speaking about hypertension when BP is above 140/90. But if we measure BP many times at rest, during daily activity, and during sleeping, there are another values for hypertension. So, for ambulatory blood pressure monitoring, 24-hour BP, systolic BP, more than 130 and diastolic more than 80 is classified like hypertension. Is average during 24 hours more than 130 and more than 80, this patient classified like hypertensive patient. At daytime, BP more than 135 and systolic and more than 85 diastolic, and at night time more than 120/70. Why 24-hour mean BP is lower compared with office BP? Because we include measurement at night time, and we already told that at night BP in healthy person drop. So in hypertensive person it should have to be lower also. That's why threshold for hypertension in 24-hour monitoring is lower than in office BP measurement. Indications for 24-hour Holter BP monitoring. To confirm a suspicion of an initial diagnosis of hypertension, it means that we have to use this monitor for many time BP measurement during 24 hours in patient with borderline hypertension, when patient BP in office visit is very closely to 140/90. If patient come with BP level around 200 above 100, no need to do 24-hour monitoring, because in this case we are sure that this patient has hypertension. But if we are not sure, we have to do monitoring. For screening and evaluation of mask hypertension, we also used this device to reveal white coat hypertension, to find out suspected episodic hypertension, for example, in case of pheochromocytoma, for the assessment of nocturnal decrease in blood pressure, to follow up of hypertensive therapies, to reveal orthostatic hypertension and supine hypertension. And let me explain some of these definitions. What is it white coat hypertension? A diagnosis of white coat hypertension is based on an office blood pressure of 130 over 80 mm or higher in individuals with normal ambulatory BP measurement. So if patient come to the doctor, he became excited, became nervous and shows something like crisis. But it is not really hypertension because when he go home, BP will drop and be normal. Mask hypertension occurs when patient has out-of-office hypertension that is not apparent in clinic BP reading, normal in office blood pressure reading, but is evident with ambulatory BP measurement. So some patient may come to you and shows a normal BP level, but for example, if he works at night time he may have very high BP level. That's why you have to find it with the help of ambulatory BP measurement. And now I want to show you scheme. How does it look like 24-hour BP measurement? In the horizontal line, you can see the time, 24 hours BP measurement. And in vertical line, BP level. Upper yellow line shows us systolic BP. Lower yellow line, diastolic BP. And in this patient, BP is very closely to normal. And you have to know, have to remember that BP usually changes its level during daily activity. And you see at night present dipping pattern. At night time when patients sleep, BP became lower than at daytime. And you see in the first measurement in the office, BP is most high. It is around 175 above 90. And then when patients go away from the hospital, BP normalizes and shows normal level. So this patient suffer from white coat hypertension. White coat hypertension is under question. Is it norm or pathology? Patient who is predisposed to sudden and significant rise of blood pressure in stress situation also has more higher risks than patient who is calm and not shows us a rise of blood pressure in stress situation. But he has more low risk compared with a person who has stable hypertension. A real result of 24-hour BP measurement. You see patient with normal BP and drop of BP during night time. The lowest gray line indicate pulse rate, heart rate. And to compare, I want to show you result of 24-hour monitoring for patients with hypertension. You see, systolic BP is very high all the time, around 200, and diastolic also is elevated. So this patient shows hypertension and average BP will be more than normal, obviously more high. And he doesn't show so significant, he doesn't show drop of BP at all. He shows drop of BP in the morning time, but doesn't show drop of BP at night time. So he is non-dipper and it increases risk of complications, especially at night time. Now, let us speak about vascular tone, and there are few methods of its registration, which call ankle brachial index and vascular wall stiffness method. Both of them are based on sphygmography. Ankle brachial index, mostly useful for diagnosis of peripheral artery disease. Very simple method, really. For this method we need some special device because it is impossible to make auscultation of arteries on the ankle. They are deep and difficult for auscultation. So we have to put some probe to feel pulsation of this artery. And with this device, we can to measure simultaneously arterial blood pressure in the arms and in the legs, and may compare the level of blood pressure in the arm and in the ankle. Normally, it is very closely to each other, or in the ankle, something higher than in the arm. If ratio is 0 from 0 from 1 to 1.4, it is normal. Now need to do something. From 0.9 to 10, borderline. From 0.8 to 0.9, mild arterial disease, peripheral artery disease. Treat risk factors, for example, smoking. And if it is below 0.8, it is moderate to severe arterial disease. And you have to send this person to the surgeon, to vascular specialist. This device possible to use for registration of sphygmogram. This device possible to use to measure ankle brachial index and vascular wall stiffness. This device has cuffs and probes to sense. These probes sense vascular wall movement and shows the waves of vascular wall movement, which we call sphygmogram. Normal sphygmogram. There are few parts of sphygmogram: anagrota, catagrota, incisura, and additional wave or secondary increase. Very important that there is incisura and additional wave. It is so-called reflected additional wave, and it helps us to assess vascular wall stiffness. To measure vascular wall stiffness, we may use few parameters. One of them, maybe most famous, is pulse wave velocity. Pulse wave velocity is the velocity at which the blood pressure pulse propagates through the circulatory system, usually an artery or a combined length of arteries. Pulse wave velocity is used clinically as a measure of arterial stiffness and can be readily measured non-invasively in humans with measurement of carotid to femoral pulse wave velocity being the recommended method. Current guidelines by European Society of Hypertension state that a measured pulse wave velocity larger than 90 meters or then, 10 meters per second can be considered an independent marker of end organ damage. So, more stiff blood flow, more high risk factors, especially in hypertension. More stiff blood flow mostly became with aging, when there are a lot of atherosclerotic plaques in the big artery, in aorta first of all. And we can measure stiffness of aorta and large vessels by measurement of pulse wave velocity. How to do it? We have to detect pulse wave on the neck, on the carotid artery, and pulse wave on the femoral artery with the help of the device, with some special sensor. And usually, pulse wave comes firstly from the heart to the carotid artery, because carotid artery is more closely to heart compared with femoral artery. And after some period of time, after some delay, pulse wave will appear in femoral artery. This delay you can see here. Right, upper curve is pulse wave sigmogram is sigmogram of carotid artery, low green curve, sigmogram of femoral artery. And in femoral artery, pulse appears later. So this delay means the time which need for a pulse wave to come from heart to the femoral artery. And pulse wave velocity measured like distance between carotid artery and femoral artery and divided to time of delay of pulse wave. Also, there are few measurements um, of aortic stiffness, of large artery stiffness. First of all, it is augmentation index, is indirect measure of arterial stiffness and increases with age, and it is calculated as augmentation pressure divided by pulse pressure and multiplied by 100 to give a percentage. With an increase in stiffness, there is faster propagation of the forward pulse wave as well as more rapid reflected wave. So augmentation index is augmentation pressure from from this patch to this reflected wave divided by pulse pressure. It was divided automatically. Also automatically is calculated central aortic pressure, which is a potential surrogate of brachial blood pressure. It directly reflects the status of central aorta. Non-invasive measurement of central aortic pressure becomes a crucial technique of great interest. And now let us have 5 minutes for break, and then we'll continue our lecture, which include more interesting methods for diagnosis of ischemia and arrhythmia in patients with cardiovascular disease. 5 minutes for break. Okay, break is over. Let us continue our lecture. Exercise and medical ECG tests. Cardiac, which another name, stress test. Cardiac stress testing most commonly used for diagnostics of stable coronary artery disease, CAD. Typical or defined angina, another name of coronary artery disease, can be defined as substernal chest pain or discomfort that is provoked by exertion or emotional stress, relieved by rest and or nitroglycerin. Also can be atypical or probable angina when chest pain or discomfort follow only by one of these symptoms, may be provoked by exertion or may relieved by rest or nitroglycerin. Also can be uh, chest pain which is not cardiac. And it is important to know for indications of stress test. So can be typical chest pain, atypical chest pain, and non-angina, which not include any of these symptoms, two of these symptoms. Pain in the chest, but without relation with exercise and rest. And we have to assess pretest probability of coronary artery disease to decide, do we have to use stress test or no need to do stress test. And pretest probability, moderate pretest probability is indication for stress test. Moderate pretest probability depends on sex and age and type of pain, character of pain. And you see moderate pretest probability in green color in this picture. Patients with a low probability of CAD have a high risk of false positive results and may end up further unnecessary invasive testing without changing patient's outcome. Those with high pretest probability have a high risk for false negative results that can miss a critical diagnosis. Therefore, these patients should proceed directly to a more confirmatory testing such as cardiac catheterization. So, stress tests are good method, but not the best nowadays in the diagnosis of CAD. So we have to use it mostly like first line method, like screening method in patient with moderate pretest probability of stable angina. Stress testing is most clinically useful in intermediate risk patient for CAD that will help further reclassify this patient into a low risk and high risk depending on the stress test result. Stress testing can also be used to measure exercise capacity, evaluate ischemia in patients who are already started on medical therapy for known CAD. There is last guidelines for exercise testing, but the age it was created in 2002 year. So it was created 20 years ago and no new guidelines for exercise testing because Imaging method is more good for diagnosis of stable coronary artery disease. But in clinical practice, we still use stress test, and exercise test is divided to two types. Cycling test, when patient do exercise with the help of some special bicycle device. Electrodes on patient's wall, chest electrodes and standard electrodes instead of arms and legs on patient trunk. BP measurement and ECG control during this exercise, which has standard level. Steps increase step by step, and all the time for all patients has the same standard level to classify exercise tolerance in patients. Treadmill test. Here is the scheme. The same electrodes, blood pressure cuff, contact with screen where placed ECG, but patient walk on treadmill. And we can automatically control the speed of the treadmill and the angle of the treadmill, which looks like walking to the hill. No real treadmill test. Patient with wires and on the treadmill and doctor who is nearby and follow patient in ECG in real time. What do we find in ECG? We try to find signs of angina. Main ECG sign of angina is ST segment depression. You can see clearly ST segment depression after stress in short small ECG in the left upper corner. ST segment depression. But ST segment depression may be not only horizontal like is presented in the left side picture. ST segment depression may be upsloping, downsloping, and horizontal. Horizontal more than 1 millimeter and downsloping ST segment depression is typical for angina attack. Upsloping ST segment depression is under question because can appear even in person without angina. If it is significant, more than 1 millimeter, 0.08 millisecond after D point, only in this case we classify it like abnormal. So type and depth of ST segment depression after stress is also significant. Now I want to show you a real ECG which we can see in real patient. Not only cycling and treadmill may be physical stress test. Also can be walking, climbing to the stairs. And in this case, patient did climbing to the stairs. We have to do ECG before stress and ECG after stress. You can see in leads V4, V5 and V6, even before stress, that present mild ST segment depression and biphasic T wave. But after stress test, this depression is more and more significant. It became more deep than before stress, and this depth increased more than 1 millimeter. So it confirmed positive result. It confirmed coronary artery disease in this person. Here, ECG before and after physical exercise, and physical exercise was done by cycling. Before cycling, ST is on isoline. After cycling, you see ST is below isoline and this patient also shows angina, and this stress test helps to confirm this diagnosis. But exercise stress test is more safe compared with pharmacological stress test. But also it is stress, it is unusual condition for patient and it can lead to complications. That's why we have to stop it in time. Absolute indication to stop stress test. Drop in systolic blood pressure more than 10 millimeter from baseline accompanied by ischemia. If BP drop, it means that heart has very significant ischemia and it can lead even to necrosis and other complications. It may lead to myocardial infarction type 2. That's why you have to stop exercise immediately. Moderate to severe angina. If patients feel chest pain, significant chest pain, even without ST segment depression, because in some patients, present delay firstly appears symptoms of angina, and after few seconds, sometimes 1 to 2 minutes, changes in ECG. So if patient suffer from significant pain, you have to stop. Increase nervous system symptoms, ataxia, dizziness, or near syncope. Of course, you have to stop. Signs of poor perfusion, cyanosis or pallor. Nervous system symptoms, also signs of poor perfusion, but poor perfusion of the brain. Technical difficulties in monitoring ECG or systolic BP also are indications for terminating. So if patient moves very much, there are many artifacts in ECG, and if doctor cannot clearly see by baseline and ST segment, no reasons to continue stress test. Subjects desire to stop. If patient is tired, if patient don't feel well, he wants to stop. No, you have to stop. Sustained ventricular tachycardia. ST elevation in lead without diagnostic Q waves. Also may transform to myocardial infarction. And can be relative indications. There are a lot of relative indications, but one of them is most common indication. It is hypertensive response, systolic blood pressure more than 250 millimeter mercury. So mostly we stop stress test if BP is elevated, or if there is significant ST segment depression, we see that patient already suffer from angina, no need to continue stress test. Most common indications for terminating exercise stress testing in real condition. Contraindication to exercise testing. We shouldn't harm patient with this diagnostic procedure. Absolute contraindications include acute myocardial infarction within 2 days, high-risk unstable angina, uncontrolled cardiac arrhythmias, symptomatic severe aortic stenosis, uncontrolled symptomatic heart failure, acute pulmonary embolism or pulmonary infarction, myocarditis or pericarditis, and aortic dissection, and can be also relative contraindications. Why do we have all this list? When to stop and who cannot do stress test? Because stress test may provoke MI or life-threatening arrhythmias. In the upper ECG, you can see exercise-induced ventricular tachycardia. You see, during exercise, initially sinus rhythm, then develops ventricular tachycardia. This arrhythmia is dangerous. In the middle ECD, also ventricular tachycardia, but even more dangerous because it is polymorphic. And in low ECD, you see after stress, patient shows ST segment elevation and pathological Q waves. So stress provoke rupture of the plaque and development of myocardial infarction. Very rare, but stress tests can cause sudden death due to different arrhythmia, mostly ventricular fibrillation. That's why in the diagnostic room, doctor have to have defibrillator to save patient if this dangerous complication develops. That's why in one new guidelines from 2019, European Society guidelines for the diagnosis and management of chronic coronary syndromes, uh, stress test, exercise stress test is not so commonly recommended. It may be dangerous, and now we have more comfortable, more safe imaging tests, but they are not available everywhere, unfortunately, and they are very expensive. Exercise CCD by European Society is recommended for the assessment of exercise tolerance, symptoms, arrhythmias, BP response, and event risk in selected patients. Exercise ECG has inferior diagnostic performance compared with diagnostic imaging tests and has limited power to rule in or rule out obstructive coronary artery disease. Uh, in the last lecture for functional diagnostic, you will discuss with Professor Lekanogov imaging testing for CAD. Exercise CCD is not recommended for diagnostic purposes in patients with ST initial at rest ST depression more than 1 millimeter or who had been treated with digitalis because it cannot be so sensitive for diagnosis of angina pectoris. Also, we can use pharmacological stress tests, not exercise, but pharmacological. They also will lead to overload of the heart, to increase in oxygen demand, and helps to reveal angina, but also may lead to complication and have to be done under doctor's control. Pharmacologic stress testing is a method of testing the functional capacity of the heart by administration certain medication. These medications mimic the response of the heart to physical stress. Pharmacologic stress test used in patient if patient is unable to do exercise, cycling or walk on a treadmill. We may use for test drugs like adenosine, dobutamine, or dipyridamole. Pharmacologic stress testing may be used in combination with imaging modalities such as radionuclide imaging and echocardiography. So not only with ECG, which we'll discuss today, also with imaging method. And most commonly recommended are drugs adenosine, dobutamine, or dipyridamole with intravenous injection of one of these drugs. Adenosine and dipyridamole are vasodilators. Vasodilators do not really stress the heart and create a coronary still phenomenon by temporarily increasing blood flow to non-diseased vessels of the coronary vasculature that can be visualized on nuclear imaging. And also, it can be seen in ECG by ST segment depression. So, dipyridamole and adenosine dilate coronary vessels, but they dilate coronary vessels more significantly when there are no plaques. in healthy vessels are dilated more than obstructed vessels. That's why blood flow goes to healthy vessels. And in unhealthy vessels, less blood. That's why appears ischemia in this region, which shows us ST segment depression in ECG. Dobutamine is an alternative drug that acts as an inotrope and can be used in pharmacological stress testing. So the dobutamine looks like works like physical stress test, like exercise. It can be used in patients who have contraindications to pharmacologic vasodilator stress agents, such as in patients who have severe respiratory disease like asthma or COPD. So the adenosine and dipridamole are superior to the butamine, but if present comorbidities, we use the butamine stress test. Because the butamine may stimulate sympathetic nervous system and it can lead to more complications compared with vasodilators. Indications for pharmacologic stress testing. Why not exercise? Why pharmacologic? For example, if patient is unable to do exercise, no, for example, if he has joint pain. Also, vasospastic angina doesn't provoke by exercise. Severe heart failure, patient unable to do exercise. High systolic blood pressure, because if it initially is more than 200, it will rise during stress test and we cannot continue stress station. Patient with a history of aortic stenosis, myocardial infarction in the last week, acute pulmonary embolism, acute inflammation of pericardium or myocardium, and severe pulmonary hypertension. So mostly it is a company disease which don't permit patient to do exercise. And now let us go to some ECD, to some method of detection of electrical activity of the heart, which are semi-invisible or invisible. And we'll start with transesophageal electrophysiological study. Also can be intracardiac electrophysiological study or endocardial electrophysiological study, which is more invasive. Transesophageal electrophysiological study is more cheap and more available. Can be done even in outpatient department. Transesophageal electrophysiologic study is a semi-invasive method of arterial stimulation and recording. How do we do it? We introduce electrode through the mouth or more commonly through the nose to the esophageal and move it to the level of the atrium. Stop it at the level of the atrium. And we can detect more clearly atrial activity. In surface ECD, P wave may be not visible. It can be small in amplitude initially, or P wave may be hidden inside T wave or QRS complex. And for the diagnosis of type of supraventricular arrhythmia is necessary to find P wave. That's why we put electrode more closely to the heart and can detect P wave. And you, in the right picture, you can see ECG. In upper ECG, you see near normal P wave because the tip of electrode is far from the atrium. In the depth of 32 centimeter, more higher P wave, and it has another appearance at called RA wave. Then amplitude increase, then electrode usually move deeper to the stomach and more far from the left atrium. That's why amplitude of P wave decreased and became near the same like surface ECG. Also, if we send some electrical impulse to this electrode, which is very closely to the heart, to the atrium, we may stimulate atrium with these impulses. So, TEEPS indicated for evaluation of the function of sinoatrial node, including the sinoatrial node recovery time and sinoatrial conduction time, to confirm the presence of sick sinus syndrome. To measure refractory periods of the atrial ventricles. For the diagnosis, induction and termination of supraventricular tachycardia. Pace the heart temporarily in patient with severe bradycardia in the ward in urgent situation. Perform heart pacing loading tests in patients who are not suitable for exercise test. So, I go back to exercise test. If exercise patient is unable to do exercise, you may do pharmacological stress test or may do stimulation of the atrium. With stimulus, we may send with more faster rate than normal patient rate. With rate, for example, 100, then increase up to 120, and it will increase oxygen demand, similar to exercise stress test. Also, in case of very significant bradycardia, we have to increase heart rate with external stimulus. We can send stimulus with the rate around 60 per minute, and patient who has before 30 beats per minute will feel better. Also, we can send stimulus which can provoke supraventricular arrhythmia, and we can indicate clearly P waves to know where does this arrhythmia come from. And also we can send fast electrical stimulus to terminate this supraventricular tachycardia and atrial flutter. How does looks ECG, real ECG? In the left ECG, you can see surface ECG, low line, and intraesophageal ECG from intraesophageal electrodes. You can see so-called A wave, atrial wave. Instead of P wave, we call it A wave. And V wave, it is QRS complex. So you see amplitude of atrial wave is more higher, is clearly visible, and its amplitude is very closely to ventricular amplitude, to amplitude of QRS complex. And we can see in the right side ECG also ECG, transesophageal electrocardiogram, and chest leads from surface ECG V2 and V3. In chest lead, we see tachyarrhythmia, but we cannot see all wave from the atrium. You see in the transesophageal electrogram that there are two A waves before each QRS complex. It means that this patient suffer from flutter ratio 2 to 1. In surface ECG, these waves are not visible. That's why more difficult to make diagnosis. Here we can see in the left ECG initially tachycardia, supraventricular tachycardia, and you see not so clearly visible, but many fast vertical line is sent from the electrode, and it stop re-entry in the heart and stop paroxysm of supraventricular tachycardia. You see at the end of the ECG normal sinus rhythm, more slowly rhythm. The same for right side ECG. Many impulses stop paroxysmal supraventricular tachycardia, then sinus rhythm, but at the end, recurrent paroxysm of supraventricular tachycardia, which will be treated again by sending fast extra impulses. Also, we can use it for the diagnosis of sick sinus syndrome. In this case, we send impulses in the heart to control heart rate within 1 to 2 minutes. Then suddenly we stop extra impulses and wait when patient sinus node starts its work. In left side picture, in upper ECG, you can see patient with normal sinoatrial node. Vertical line means pacing. At the left part of ECG, pacing. Then pacing suddenly stop, but without long-lasting pause, appears P wave and sinus node start its work. In the low ECG, again pacing, then suddenly pacing stop, but pause lasts longer. It means that sinoatrial not work properly, but not too bad. It is not sick sinus syndrome yet. Only some initial damage. In the picture of the right side, after stopping extra stimulation, you see very long pause, around 10 seconds. This is typical for significant damage of sinoatrial node function, which call sick sinus syndrome. So we can use esophageal stimulation for diagnosis of sick sinus syndrome. DEBF is contraindicated in the following situation: acute upper respiratory tract inflammation, large aortic aneurysm, severe hypertension or uncontrolled hypertension, severe esophageal disease and severe cardiac disease, cachexia or other status in which the patient is intolerant to catheter insertion. So mostly contraindications are difficult in catheter insertion. Patients sometimes may refuse from this procedure because he is afraid of it. Of course, you cannot do it also. As a diagnostic tool, TEPS has some limitation. One of the most important limitations of TEPS is the lack of tolerable ventricular stimulation in the majority of patients and the lack of His bundle recording, which has a crucial role in the diagnosis of some arrhythmias. So, near the esophagus, placed on the atrium, ventricle has distance, so we cannot sense it so clearly and we cannot, as a rule, stimulate it. And there is some specific potential, it called bundle of His potential, which may be sensed if you place electrode near the bundle of His. We cannot place electrode near the bundle of His in this method. TEPS provides an important electrophysiology basis before invasive and electrophysiological study, EPS. It can be applied for screening and provide the ambulatory observation during consultation. So it may be done in outpatient like screening procedure to decide does this patient need invasive procedure which call endocardial electrophysiological studies or he needn't it. Now let's go to endocardial electrophysiology study or electrophysiology study. A cardiac electrophysiology study, EP test or EP study, is a minimal invasive procedure using catheters introduced through a vein or artery to record electrical activity from within the heart. It is minimally invasive because catheter introduced through peripheral vein or through peripheral arteries, but it have to move to the heart, and its movement is unusual situation for patient heart, so it can lead to different complications. It may cause arrhythmias, so it cannot be done for outpatient. It have to be done only in special cardiovascular department if doctor has some expensive equipment. How does this procedure likes? These doctors are cardiac surgeon, and it looks like surgery without open chest or open abdominal cavity. We introduce catheter, minimal invasive surgery, and we move it to the heart under the control of X-ray. You see the screen of X-ray, and in another screen you can see ECG, but it is ECG which is detected not from the surface, it is detected from the endocardial part of the heart. It is detected inside the heart. The interpretation of an electrophysiological study include the assessment of both morphology and the timing of intracardiac electrograms at baseline and after program electrical stimulation of the heart in relation to two or more simultaneously recorded surface ECG signals. So, near the same, we detect ECG by electrodes which are inside the heart, and also we may stimulate the heart from the same electrode. It is near the same with transesophageal electrophysiological study. Usually there are 4 electrodes in the heart. One electrode is placed near sinoatrial notch and detect its activity. You see how does it look like. Another electrode is placed near the bundle of His, and we have a wave potential of bundle of His. And another third electrode is in the right ventricle. At the same time, we detect surface ECG. And we may move all these electrodes, and in each electrodes may be a few places for detection of electrical activity. And one more electrode may be introduced in the coronary sinus to detect activity of the left sides of the heart. How does it look like in a real situation? Under X-ray control, catheter in the right atrium, catheter besides AV node, catheter in the right ventricle, and coronary sinus catheter. All of them may detect ECG. And how does look ECG like? Upper 3 lines are surface ECG, first, second leads, and V1 lead. Next line, HRA, it is atrial activity. His bundle of his activity, and for next coronary sinus, the electrode moves through the coronary sinus and detect electrical activity of the coronary sinus. Also, we can sense energy to this electrode, which may lead to destruction of the pathological part of endocardium and myocardium, which usually produce arrhythmia. This procedure called ablation, but we'll discuss it something later. Major indications for electrophysiological study: evaluation of syncope, definite diagnosis of subjective palpitation or of a documented cardiac arrhythmia. We may provoke arrhythmias, but not only supraventricular, we can provoke ventricular arrhythmias also. Evaluation and treatment of patient with Wolff-Parkinson-White syndrome. We can do ablation for this patient during the same procedure. Risk stratification of sudden cardiac death. Can we provoke ventricular fibrillation, or we cannot provoke during this procedure? But it is, of course, dangerous and may be done only in special department. This electrical activity is recorded when the heart is in a normal rhythm, sinus rhythm, and during any abnormal heart rhythm that can be induced by electrophysiological study. EP studies are used to investigate the cause, location of origin, and best treatment for various abnormal heart rhythms, and are often followed by a catheter ablation during the same procedure. Catheter ablation is a procedure that uses radiofrequency energy, similar to microwave heat, to destroy a small area of heart tissue that is causing rapid and irregular heartbeats. Destroying this tissue helps restore heart's regular rhythm. The procedure is also called radiofrequency ablation. What do we do in case of radiofrequency ablation? We put catheter inside the heart. When we place the tip of catheter near pathological part of the heart which produce arrhythmia. Before radiofrequency ablation, we do electrophysiology study to find the source of arrhythmia. When we introduce electrode inside the heart and check electrical activity of the heart. And when we make proper diagnosis, we put radiofrequency, we put catheter for radiofrequency ablation and send electrical energy to the catheter for destruction of myocardial tissue. Examples of catheter radiofrequency ablation. It is very helpful in patients with WPW syndrome. You see in the left part of ECG, accessory pathway potential. We place electrodes in the position where present accessory pathway. Send energy, present destruction of additional pathway, and now after it ECG became normal. It is difficult for you to check intracardiac ECG. Look at surface ECG, first, second, and third line from the upper part of this picture. You see delta wave initially, and after catheter ablation, delta wave disappear and PQ interval became longer and QRS complex became not so broad because accessory pathway now is absent and patient will no more suffer from supraventricular paroxysmal tachycardia. Also can be radiofrequency ablation in case of paroxysmal ventricular tachycardia. You have to put electrodes in the place of origin of ventricular tachycardia and make damage of these parts. Ablation of scar-related ventricular tachycardia. You see in low ECG paroxysm of ventricular tachycardia which suddenly stop after ablation of these pathological sources. Here are electrical energy which is sent for ablation. Of course, this electrophysiological study is good procedure for diagnosis and for treatment, but it is invisible and may lead to some complication. Maybe arterial injury, thrombophlebitis, pulmonary embolism, even cardiac perforation. Maybe catheter-induced permanent atrioventricular block, infection, and pericardial infusion. But fortunately, these complications are rare, and if doctors has experience, they never do this complication. So this procedure have to be done by doctors which have experience for this procedure. Now time is over. Thank you for your attention and goodbye.